was hormone replacement therapy helpful in reducing your lipid markers?
Yes, absolutely. Yeah. We tend to be very siloed in medicine. We're like, oh, those sex hormones thing, that's a GYN problem. That's not a cardiology problem. And like, no, we have a systemic estrogen deficiency that is impacting every single system.
Is every woman a candidate for hormone replacement therapy?
I think it is. Every individual is worth having a conversation around it. There's very few people that it's not appropriate for. Like I use the example of vaginal estrogen should be given to everyone. You and I have seen over the years of working in hospitals what happens when women don't have enough adequate estrogen and develop urosepsis, and in many instances get very sick, end up in the ICU, and in some instances can die, and that can be largely preventable.
Cynthia, thanks so much for joining me today at Extend.
Yeah, I've been so looking forward to having this conversation with you in real life.
I know, this is fantastic. We've been talking about this for a long time, but you're all the way out in Virginia, and we tape in person because I just feel like it's such a better conversation in person, you know?
You really do. And as someone who's just ventured into the in-person podcasting space for my own podcast, I agree. There's a degree of intimacy and connection that you miss when you're doing it over Zoom or Riverside or any of the other options that we use to make these happen.
Exactly. And it just goes to show you, like, there is something really real about how physical connection really does create, I think, better health, better longevity, better mental space, all of it.
Oh, it's also important. And these conversations are important because we have an ability to share the knowledge and the experiences that we have as clinicians and make it accessible for people everywhere.
Exactly. And this is one of my favorite reasons for having you is because we're both clinicians. We're both seeing a lot of patients all the time. And, you know, I think there is a jump from what people talk about to what really happens, right?
Well, and I think that there's well-intended messaging that comes out from non-clinicians. As an example, but, you know, you worked in surgery. I was an ER nurse before I worked in cardiology. I have seen the sickest of the sick types of patients. And so it just gives you a breadth of perspective that I might not otherwise have. But I always say that I'm so grateful for those experiences, but I like a lot less stress in my life, like what I used to experience years ago.
Oh, absolutely. So you don't miss seeing 80 patients a day? And
No. No, in fact, I was talking to someone recently about how they used to add on more patients to when we were in clinic. And they would say, well, you don't need to take lunch, do you?
That happened to me all the time.
And I was like, well, yeah, I actually do need to eat.
Right.
And I do need to empty my bladder, and I do need to drink some water. But you would just say, okay. What I started doing is I would say, I'd rather you give me time at lunch to have even 15 minutes of a break and just add them earlier in the morning. So that became, they knew that they could add someone at 7:30 in the morning before I started my usual patients.
It's so crazy. And, you know, like being in the medical field, it's mind-blowing the number of patients that are out there. I mean, it's just way too many people are sick. And it's all, when I was doing surgery, it's like, why does everyone in the world need surgery? This shouldn't be this way, right? And it's just nice to be on the other side of the coin now where I'm trying to prevent people from going to surgery for all sorts of reasons, right?
Yeah, well, and it's interesting because I spent 16 years working in clinical cardiology. And I remember it was probably the last 3 or 4 years, I got very interested in lifestyle and very interested in talking to my patients about nutrition. And most of my colleagues were tolerant at best. And they would say, this is our nurse practitioner who likes to talk about food. And then they would refer people to me. And I was like, oh, this is great. But what I found is that so many of us are just so indoctrinated in that traditional allopathic model that even the patients were like, Cynthia, I'm not gonna stop smoking. I'm not going to change my diet. I'm not going to start exercising. Just give me the pill. And that to me was so disheartening because I would say to them, if I could get you to eat less often, and if I could get you to eat more protein and knock out a lot of the processed food that you're consuming, and if I could get you to stop smoking, you know, maybe you wouldn't have this progressive worsening vascular disease or progressively worsening diabetes. And I think in many instances, our patients have just been conditioned to ask for the pill instead of doing the hard, and I know it is hard work, the lifestyle piece, which is absolutely essential for health.
Yeah, and so you and I are in total agreement about that. And what I also tell my patients now is the pharmaceuticals will have maybe 1/3 or even 1/4 of the effect that you're looking for. It's really the diet, exercise, lifestyle, stress management, sleep piece that's going to have 80% of the effect or more and make the pharmaceuticals more effective. And my whole goal with patients is to get them off their pharmaceuticals at some point, right? And so that's never going to happen if you don't get the lifestyle piece correct.
Right. And I think for a lot of people, and maybe in their teens, 20s, and 30s, they can get away with eating whatever they want and not exercising and engaging in any type of extraneous, illicit experience. But I think as we start navigating perimenopause, andropause, menopause, the game shifts. I mean, I tell everyone that, my one big vice that's left is dark chocolate, but even that is not something that I can do all day, all the time. I mean, those differences in lifestyle make an enormous impact. And I think for a lot of individuals, they assume that what they see on social media are people that live a lifestyle where they get to engage in whatever they want. And I'm the first person to say, everything has to get more dialed in the older that we get. That's the unfortunate truth. And I'm very honest with patients when I just say that it's like we're constantly fine-tuning a piece of sculpture. If that's how you want to think about it, it's like we're constantly honing that sculpture. And that's what allows us to continue to have that high quality of life, which I know most of us are looking for.
Exactly. And, you eventually get to a point in this journey of modifying your lifestyle that it actually feels much better and it becomes more inspiring to live with a lifestyle that promotes health versus degrades it all the time, right? And so I actually feel so much better doing the things that I do now versus what I was doing 10 years ago. And I'm more inspired to do these things on a daily basis. You just have to find that moment where you kind of turn the corner into this new lifestyle, you sink into it, and then you love it.
Do you ever look back retrospectively and think about when you were in the heyday of your surgical residency or even first practicing as a surgeon, the amount of stress and the lack of sleep and the poor quality food that you ate because that's all you could grab in the hospital because the hospital is littered with junk food.
Oh, it's ridiculous.
All of the nurses' lounges were littered with junk food. I mean, in Baltimore, it was Krispy Kreme donuts are a big thing.
Krispy Kreme everywhere. So same in California.
Yeah.
I look back and it was like the exact opposite of how you should be living. You're completely stressed out all the time. And it's not just doctors and nurse practitioners that live this way. I think a lot of us live this lifestyle where we wake up in the morning stressed. We did not get a good night of sleep the night before. We eat garbage because we're stressed and we're rushed. And then it just keeps going in this horrible cycle all day until you finally crash at night after a couple of drinks because it's the only thing to get you to unwind. And you get another bad night of sleep. And it just keeps going and going in that cycle. I think a lot of people can appreciate that because a lot of people get stuck in that cycle. And you can blame whatever you want. You can blame your career. You can blame family stresses. You can blame, there's a lot of reasons that you get into that cycle. But there's a lot of people also living a good, not necessarily a good, but also maybe a clean lifestyle that also are in these careers too. So it can be done, right?
Yeah, and I think a lot of it is choices. And I think sometimes we don't realize that it's kind of like a boulder going downhill.
Yes.
That it's usually one choice after another that kind of leads to that feeling.
Right.
Many people feel powerless.
Yeah.
They feel like they're in a position where they can't make a change, they can't course correct. And so in many instances, it's helping empower people to understanding like we can start to change the trajectory of the direction in which we are going. And I think for a lot of us, myself included, it wasn't until I hit the wall of perimenopause that all of a sudden I really started to question everything in my life because I was like, all the things that I used to do that served me very well as a very high-functioning, type A, successful individual no longer serve me. And that word pause is the word that I always encourage people to consider, irrespective of whether we're male or female, is understanding that it's a time in our lives where we are invited to change. We are invited to kind of pause and reflect. And for so many of us, we've been in these positions where we're go, 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 go all the time, that all of a sudden it's like, you want me to stop and think? I've been on autopilot for 10 years, 15 years, 20 years.
Right. I love that. So pause, menopause, andropause, take some time to stop, reevaluate your choices, your life, and maybe choose a different direction.
Yeah.
Right?
Well, and I think for a lot of people, they can course correct, and that then leads to exponential gains emotionally, spiritually, physically, et cetera. or they can continue on that same path. And I certainly saw a lot of those people. I mean, it isn't unique to just healthcare, but
Right.
those are the examples that I think of the people who just looked haggard and exhausted and tired all the time.
Right, absolutely. So in your practice, so you're doing cardiology for many, many years, and now you're focused on women's health, integrative health, lifestyle medicine. How did that transition occur?
Life imitates art. So I hit that wall, as I referred to. So, over 10 years ago, I could barely get out of bed. I was exhausted. I wasn't depressed. Clearly something hormonal was happening, but nothing had prepared me. Not my mom, not my GYN, not my girlfriends, because women in many instances 10 plus years ago weren't talking about the changes that were happening in our bodies. Menopause was so many years away. I mean, that's never going to be here. And so I think for me, it was started with the overall exhaustion, the feeling like I couldn't keep up with myself. I'd always done pretty intense exercise, and all of a sudden I could barely get through a class. My hair was falling out. I was gaining weight. I was really, really tired. And at the time, I had 2 young kids. My husband did a lot of international travel. And for me, I think it was the realization that something wasn't quite right. And it was trying to figure that out for myself. And through me determining what was going on with my own health, that pause definitely encouraged me to think about what was the next half of my life going to be like.
Wow.
Because if this is what my life was like right now, I was like, this is not sustainable. Absolutely not sustainable. And so, I think I went the traditional allopathic route initially, and that's when my GYN offered me the pill, an IUD, an ablation, or a hysterectomy. And I said, no, 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 and no.
Yeah.
And then I kind of pivoted and I started getting more interested in the lifestyle piece and started examining, like, what's the research really telling us? Because I ultimately always go back to what research has been done, not a lot. What are the things that we know in terms of lifestyle have the greatest net benefits? And so for me, that led me to intermittent fasting. And I always tell people, I came to intermittent fasting like many people do, with a desire to lose weight. What kept me there was just how much better I felt. And so that was the beginning of this shift. And then that led itself to, I really started questioning my job. And I remember I went to the practice I worked for and I said, I'm not growing intellectually anymore. And my practice was incredibly good to me. I worked at that point 2 days a week, 2 essentially 6-hour days, because they allowed me to keep reducing my hours to work around my kids' stuff. And they just said, we'll give you anything you want. And I said, it has nothing to do with you all. It's everything to do with me. I'm just not growing anymore. And so I left, 9 years ago without a business plan, without any idea of what I was going to do. I said, I know I'm going to be successful. That was either, arrogance or just complete naivete. And so
Manifestation.
Yes. And so my husband, who's an engineer, is very fiscally conservative, thought I'd lost my mind. He's like, is this a midlife crisis? Is this what people talk about? And so the irony is that almost instantaneously, women started coming to me because they felt like I was talking about things that they were experiencing, and I was listening in a different way. And so I started with group programs, and that kind of morphed into one-on-one programs. And so that just started this other path that was incredibly fulfilling because I was meeting women's needs in a way that they were not being met at that time. And then it morphed into a lot of other wonderful things. But I think the biggest impetus was my own healthcare hiccup, my own healthcare issue that led to me deciding that I was not willing to walk around feeling like I had brain fog. I was exhausted all the time. My hair was falling out. Very clearly, there were a lot of hormonal imbalances, not the least of which I have thin phenotype PCOS. And so I've always been low in progesterone, and that just magnified all these low progesterone symptoms. And so I think for me, my own journey is what allowed me to pivot and to then turn into a position where I had a larger platform in which to speak to women and inspire them and their families to live differently. I feel like the tide has shifted a great deal in 10 years.
Yeah.
It's very different now than it was even 9 years ago so it was April 1st, 2016 is when I left traditional allopathic medicine and never looked back, never questioned that decision at all.
That was kind of the time period too that I made the decision to start changing my career, because I had taken a course in functional medicine. And I just learned 2 things that completely changed the trajectory of my own health. And I, same as you, like I incorporate those into my life. I'm like, I have to talk about this to all the men and women out there that don't have this information, you know?
Yeah. Well, and it's interesting because I didn't mention, but I did initially a functional nutrition program. And that lit me up. I was like, the power of food. Oh my God, food is medicine. And so that got me interested. And that then allowed me to feel much more comfortable, confident saying, everything I've been telling patients about food is wrong.
Yeah.
Every single thing. I mean, I actually kept one sheet that the nurse practitioner service had created to talk to our patients about food, and it made me cringe.
Really?
Because it was focused on avoiding butter and avoiding ghee and consuming plant-based fats. So, Brummel and Brown and all these, canola-based spreads, those are great for you. And, eat your heart-healthy grains and, small amounts of protein and saturated fat is bad. And so when I look at that now, I should probably plaque it. But when I look at that now, it's like it makes me recognize, number one, how far I've come. And number two, I feel like I will spend the rest of my life ensuring that I'm spreading information that is actually going to be helpful to our health as opposed to detrimental. Because, we could have a whole sidebar conversation about how, my plate and the food guide pyramid and how it should really be flipped upside down and completely the opposite of what we've been telling our patients. Yeah. And it's like I always say, know better, do better. That's kind of my prevailing philosophy in life, that now I know better and now I do better. And I make sure that we talk about the conversations around lifestyle that I wasn't having, 20 years ago with patients.
Absolutely. And we were trained in medicine around the same time. And, we were taught all the same things, low saturated fat diets, low protein diets. And, the fruit pyramid had grains at the bottom of the pyramid. And that was what we would tell people, like, heart healthy grains, right? And nothing could be further from the truth now. It's exactly the opposite in my food advice too. So it sounds like you kind of landed on two of the main topics that I landed on that made a huge difference for me, which was metabolic health and hormonal health. Those are the two places I made personal changes in my own life. That's usually where I start with my patients as well, particularly after 35 and, that whole time period. And it sounds like kind of that's where you landed as the two main categories where you can really create a difference.
Well, and for me, being in cardiology, I had a bird's eye view of what does a diabetic patient's trajectory of their life look like? What does a patient that is started on a statin at a very young age, because that's back when, kind of prevailing medical dogma was, we're going to start you on a statin because you have a high LDL. We're going to put you on, this drug Tricor because your triglycerides are high, your HDL is low, but really what you need is to change your diet. Let's talk about poor metabolic health. So for me, I was talking about fasting insulins way before they became very much considered to be, this is something everyone should be asking for. And I kept saying, if we know that we can diagnose someone earlier or prevent them from developing diabetes, isn't that really the key? I actually recently, a physician said to me, I don't know how to interpret that. I said, well, let me help you because this is going to be life-changing for your patients. Don't be afraid of looking at a fasting insulin. But I was talking about fasting insulin a long time ago. And so, for me, being in cardiology, metabolic health was always something that was prevailing and important. And then because life imitates art, because I myself was a perimenopausal female, I was like, why aren't we talking about what's happening with our hormones? Like, why is my progesterone so low? Mine was even lower than low. And why am I now, relatively estrogen dominant? And let's not even talk about testosterone, but all these sex hormones, not to mention other hormones that are impacting women in particular as they're navigating this perimenopausal transition. Because if we could talk to patients about what to anticipate, then they could start making course corrections along the way, as opposed to like where I was, where I hit the wall, where it was like I had to make a lot of changes very quickly because I was unwilling to continue living like that. Not everyone is that way, but I'm kind of, I can sometimes go to extremes. But for me, it was, I had to change so many things all at once because I was unwilling and impatient, frankly, to wait forever for me to feel better. It was like, okay, what are the things that are going to yield the greatest results the fastest? And, it's like I'm always looking at it like, what's the net positive of making a lot of changes really quickly and kind of having to like go through this process and have it be uncomfortable and arduous, at least up front, and then it'll be a little bit smoother. And so that's just my personality.
Yeah, yeah.
I'm like, I will accept that suck it up kind of mentality up front.
Right.
And then, that's usually not how I encourage my patients to make changes. But for me personally, with my personality, that was better for me.
That was better for you. And some people, they just have to, people come to us, sometimes they need to make a lot of changes quickly because they've hit a wall. Maybe they're 50 pounds overweight. Maybe they are now just got a diagnosis of prediabetes or diabetes, or they come in with severe perimenopause symptoms. Sometimes those patients are willing to make changes, many changes rapidly. What I'm seeing a lot more of now, and I don't know if you are as well, you probably are, is people that are now have their minds wrapped around proactive diagnosis and being more proactive, so you can make, like you said, course corrections early so you don't end up hitting a wall in the future. And I'm really looking forward to a world where that is the standard, right?
That would be amazing. And I think for myself, being able to look retrospectively over the last 10 years, I think that the women that are in particular, and that's the population of people that I speak to, but even looking at my friends and their significant others or spouses, men go through andropause too. It's just not nearly as dramatic. And as men kind of sit back and they're looking at their wives kind of humored, like, what are they going through? I want to better understand it. And so I think from many different levels, when we're looking at these changes that are happening in sex hormones, understanding it is normal, but normal doesn't necessarily mean optimal. And how can we navigate these conversations so that people can be both proactive and feel supported? And that means having the conversations earlier. That means, when someone's 30, when, of course, they think they're going to live forever, they're never going to get sick. Even talking to my, I have a 19-year-old and explaining to him, maybe in 10 years, things will be a little bit different, but just understanding the way that things change physiologically, whether it's, bone and muscle mass, whether it is understanding the changes of losses of insulin sensitivity that can happen, just explaining to them about the physiology of their bodies so that they can be more anticipatory as opposed to reactive, which is how the traditional allopathic model is kind of designed to be. It's like, it's like whack-a-mole. Like, you got a symptom, let's hit the symptom with a pill and then we'll move on. And when another symptom develops, and to give context to listeners, as an example, like one of the frontline drugs to treat hypertension or high blood pressure is diuretic therapy, okay? And so we prescribe a lot of diuretics in cardiology. And diuretics are both good and bad, right? They can be very cost-effective. They can be very helpful for managing blood pressure. But they can also create other problems. And so certain drugs would then lead to low potassium, and so you'd add, potassium. And then, patients, if they were on enough of certain diuretics, they might end up getting gout. And so gout is this painful joint condition. And so it's just like it becomes this domino effect of you prescribe one drug to treat one issue that then begets another issue, which then begets another issue. And it just becomes this domino effect. And in fact, in cardiology, we used to not laugh, but we were humored sometimes at the amount of drugs our patients were on. Sometimes 25, 30, 50 drugs.
It's crazy.
And that was normal.
Yeah. Yeah, and that's a perfect example, I think, hypertension, of how allopathic medicine is structured, right? Someone comes in with hypertension, you don't even talk about what the cause is. Like, what's causing this hypertension? Why is your blood pressure high? We know that's multifactorial. All of those factors can be addressed, and you can reduce your blood pressure significantly. Instead, what we do is give someone a medication. A diuretic makes you basically pee volume out. So now you're dehydrating your body so that you have less volume in your blood vessels, so you don't have to have such a high blood pressure, which is so enigmatic of what every medicine basically does, right? It covers up the symptom without even addressing the problem, which is the big problem, which is the whole challenge here, right? And that's why people just get on 50 medications, one right after the other.
Well, and it's interesting. So my father passed away last year, but we would have a lot of conversations. He was put on a statin very, very early. My dad was not an obese individual. He was insulin sensitive, but we just have these genetic susceptibilities. And I would say to him, Dad, I want you to understand the side effects of this drug. And by no means, if anyone is listening that is taking a statin, I'm not suggesting that you stop it. But I would talk to him about mechanism of action. He was very smart. And I would explain to him, maybe if we could change some of the things you're doing with your diet, maybe you wouldn't need medication because you're on quite a heavy dose of this statin agent. And, ultimately we did see some side effects from the statin, but it was interesting that his prevailing perspective, and he was born in 1942, was, this is what my doctor told me to do. I'm not questioning it.
Yeah.
And,
Yeah.
you're my daughter, but you're not being objective.
Right.
And so I remember saying to my brother, I was like, it was amazing to me that generationally I would see certain types of patients that were not willing to question their provider. And I encourage everyone, ask questions. If your provider is really good at what they do, they will welcome your questions, as I encourage people to do all the time. But my dad, he was, at that kind of tail end of the 1930s into early 40s, not willing to tell his provider that he was not comfortable with that decision choice, and just took the statin, which, again, the side effects are many, and he definitely experienced them quite significantly.
Yeah, see, and I think rightfully so now things are changing. I think people are asking more questions. They can get on ChatGPT and ask ChatGPT a question. So it's great that people are asking more questions, but there's still a significant portion of the population that doesn't really ask the questions. They still do the same thing. They just take whatever the doctor prescribes, and they don't even know what it does or how it works. They just take it because my doctor told me so. A lot of times these doctors have only spent 15 minutes with them, and they're treating a number with a drug without the entire context at all, because they just don't have the time. They just prescribe the drug, and it's a tragedy, I think. I think that's why statins are the most overprescribed medication in history right now.
Well, and I personally have been told multiple times many years ago that, you have a high LDL, you should be on a statin. And I knew better, and I would just say, thank you for that information, but no, I don't. And the other thing that I think is important is that when we're having these conversations around medications, and especially about these short visits that providers are kind of beholden to because of the current medical model and insurance reimbursement, there's an interesting story that I always like to share to give everyone some perspective.
Yes.
There was a wonderful cardiologist that I work with. He was very good at what he did. And he would comment, he would say, how did you get the patient to tell you all this information? And I would say, well, I listen. And he said, well, you do more than listen. But he's like, here's the thing. You don't ever let the patient if they come in with a list of questions, he who holds the list is in control. And so his job, he say, your job, I'm going to give you some advice. Your job is to get the list away from the patient. So you control the narrative. And I remember I was so shocked that he said that out loud. And I just said, okay, thank you for that. But it reminded me that there are a lot of providers that feel that way, that they're so pressed for time that they want to ensure that they get your top question answered, but they are not going to make more time than what they are capable of in that model to answer those questions. But it's a kind of a statement of a lot of what is wrong with the current model, that providers feel that pressured that they want to have control over every variable to ensure that they can get out of that room as quickly as possible.
Yeah.
And I believe, and I endeavor, and I believe this fervently, most providers really love their patients. They love being a provider. They want to deliver high-level care. They're just incredibly constrained in the current medical model.
Yeah. I think most people go into medicine, they wish they could spend an hour with every patient and treat it like a case, right? I remember doing cases in medical school, and we would spend 3 hours discussing one case. And that's the way we learned medicine. But unfortunately, because you get paid $50 a visit by insurance, you have employees to pay, you have the lights to pay for, you have your rent. There's no way you're making all of your bills if you don't see 50 to 80 patients a day. And so you have to stay within a certain time period. And unfortunately, that's how the whole system is built right now. People can get out of this system now if they invest a little bit more money into their health by finding providers like yourself. But it does take some investment of money, time, resources. And yes, I think we have to get out of this mindset that insurance is going to pay for this, because if you think about it, you have car insurance, right? Insurance is for disasters. If your car gets into a car accident, you call your insurance and you say, hey, I got into a car accident. Will you help pay for this? You don't call your car insurance to do your oil changes, to put gas in your car. It's not meant for that. Insurance in the health world has become, yes, it's there for disasters, but it's also become kind of like a discount card. Like now I can go see that primary care doctor for a $20 copay versus the $500 or $400 I should be paying for 2 hours of this person's time to really sort through all my health issues. And unfortunately, it's not meant for that. This is the system that has been created because people expect their insurance to pay for health care. It's really there to pay for sick care and disasters, not for health care, unfortunately.
Yeah, and it's interesting. This past year, my husband got sick in the fall. I know we were talking about this before. And my husband, never having been sick a day in his life, when he started seeing the hospital bills coming in, he looked at me and he said, now I understand why we have insurance.
Right.
We didn't pay $1. And he had hospital bills that were 6 figures.
Yeah.
For 2 hospitalizations and a big surgery. And so, from that perspective, I 100% agree with you. And what's interesting is we now pay extra to a functional medicine provider. Myself, like I don't treat myself and I don't treat my husband and I don't treat my kids. And they're getting a level of care and attention that is allowing me to feel like I can exhale a little bit. And I think for many, many people, it's understanding that, yes, we have insurance for catastrophic events, God forbid, but like the day-to-day and the, having someone that can spend more time with you and can really look through your medications and, go down a rabbit hole to look at labs from a different perspective, that is the investment that we choose to make. And I always say it's a choice and it's something that we choose to make. Like we aren't people that eat out very often. And I'm like, I'd rather take that money that I would use to eat out every week and use it for, a higher level of care.
Right.
And especially for what my husband went through health-wise last year, I was like, I'm so grateful that we have the ability to do this because there were things that got missed along the way that had he been part of this practice at that time. And my husband's incredibly stubborn. I'd been trying for about 6 months. As I said to someone, you can only encourage your spouse only so much.
Yeah.
And then maybe they had to wait till they had a big hospitalization. Like, okay, I surrender.
Yeah.
Now I know that I need this level of care. But I think for so many people, we have to shift that mindset around insurance is going to cover everything to understanding that we may need to pay out of pocket for some resources and that ultimately that will allow us to, probably age in a way that allows us to be in alignment with our values.
Exactly. And that's one of my missions is to kind of uncouple these two systems. You have a sick care system and then at Next Health, we are their health, the true health system, right? And a lot of people, what they're doing now, and this is what I've done, is I only pay my insurance to cover for disasters. So I have disaster care insurance. Everything else I put into my HSA plan and I use it for my own functional medicine physician and some of the other things that I do on the health and wellness journey. And my thesis is the more I can focus on my health and wellness journey, checking my biomarkers every quarter, working with a functional provider, integrated provider, the less I'll have to use this disaster care, right? And the longer my health span. And I think the more we get our mind wrapped around creating these two separate journeys, pathways, the longer we'll all live, the more health span we'll have, but also the less we'll utilize the sick care system, right? And then that will unburden that system, making it less expensive in the long run for us. I think that's the only solution here.
Well, and it's interesting because I think a lot of people still pay $500, $600, $700 a month for insurance that they themselves are not per se using.
Right.
And that could be better spent with disaster care coverage. And that I know we max out our flex spending because that's what I use for most of my medications and things like that, as well as those monthly fees that we're paying for that functional integrative medicine care.
Right.
And it's interesting because it's starting to shift. But I think for many people, they're still kind of beholden to that kind of traditional model of, 30 years ago, yes, you probably could get most of your care in a traditional model because 30 years ago, things were very different. Even, I remember in the 1990s, ER medicine was totally different.
Absolutely.
Those ER doctors worked up everything before they called in a specialist. And then as I was kind of leaving cardiology, we would get called if a 20-year-old came in with chest pain.
Right.
Totally different emphasis.
It's crazy. I know. So let's dive into a couple of health topics that I really want to talk to you about. And I wasn't going to talk to you about this, but I think we should anyway. You mentioned statins a couple of times. And so, one of the things you said was my LDL was high and they prescribed me a statin. And I said, no way. And I would love to unpack that a little bit because I think a lot of people hear that statement. Your LDL is high, here's a prescription for Crestor, right? And so why is LDL not necessarily an indicator of heart disease?
Well, I can say that if I were to look at the way that I practiced in 2000 and 2001 when I was a new nurse practitioner, was that we really looked at this very narrow lens with what was driving, this heart disease paradigm. We weren't thinking about insulin resistance. We weren't looking at these other biomarkers. And so we would look very transparently, would say LDL must be this driver of what is leading to plaque progression, whether it's cerebral vascular, cardiovascular, peripheral vascular disease. That is what the primary driver. And so we steadfastly hung on to that model of high LDL equates with cardiovascular disease, instead of looking at other things like, low HDL being much more predictive with high triglycerides. And, it's kind of evolved, or saying to patients, your total cholesterol is high, therefore you need a statin. That is, in fact, the way that a lot of people have practiced for a very long period of time. What has started to emerge is this other, heart hypothesis, really looking at what is the primary driver of inflammation, oxidative stress. In many instances, it can be insulin resistance, but it's also looking at other types of lipoproteins and other types of lipid particles, things like apolipoprotein B, as being, one, but the torch bearer is really this lipoprotein, so Lp(a), which is both genetic. And what's interesting is if you look at a lot of individuals, and if I remember the data from my conversation with Tom Dayspring, really looking at, there's subsects of the population walking around not realizing that this elevated Lp(a) in and of itself is the driver of inflammation, oxidative stress, and can lead to this plaque burden and buildup inside our endothelium, inside the lining of our vessels. And so we've kind of starting to pivot away from that kind of heart disease paradigm. But I can tell you without question, because we get questions, thousands of questions every year around this in particular, helping people understand that LDL in and of itself is not the, forebearer of doom. And that many people, there's research coming out about these lean mass hyperresponders that, I'm one of them. I'm a lean mass hyperresponder. This is kind of a developing paradigm or differing perspective that you can have a relatively healthy lifestyle and still have this elevated LDL. It doesn't equate to having plaque burden. Now, the other side of that is, years ago, we just did stress testing. And if you really were concerned, we might do an angiogram. We might go in and look and do a cardiac cath. But now we're looking at different types of testing, looking at, a CAC, a coronary artery calcification, which that can be helpful for, looking, is that zero? If it's zero and you have abnormal lipids, that's probably not as big of a deal. Looking at, more non-invasive testing like CIMT, which is looking at your carotids, or moving to a CT angio, which for many people can be very helpful, but usually you take that along with symptoms to make a determination. There's even this clearly that now a lot of people are doing testing with. And so, thinking of LDL as the only reason or the only manifestation of this progression of cardiovascular disease is really missing an opportunity to look a little bit more deeply. And so I think most people that are developing vascular disease, there is a genetic component without question. I'm one of these people. My Lp(a), when it was first drawn, I nearly fell over. With that being said, there are ways that you can address that without a statin, but also looking at plaque burden, looking at the other diagnostic testing to see if you are at risk or if you are someone that really needs to be watched and monitored really carefully. I'm curious for you when you're working with your patients, are you doing clearly? Are you doing, you're shaking your head.
I'm shaking my head on everything that you're saying, because I think what people don't really understand, in the last 5 to 8 years, there's been a massive shift in the technology available to us to really treat cardiac disease the way we should be treating it, which is not jumping from LDL to statin. Instead, now we have a lot more clarity into what's actually happening at the vessel level of your heart. We never had this before. That's why people did stress tests, which is a way late indicator. If your heart is not getting enough blood when you're stressed, that's a problem.
Or if your EKG is...
Or if your EKG is abnormal, right? We never had this level of clarity until the last few years, I would say, where we can actually do a CT angiogram, which has better resolution than a real angiogram, because now you can see every vessel, every soft plaque, every hard plaque. But the sad thing is, for 2 decades, we've had the CAC score available. the calcium score, but insurance never paid for it, which made zero sense to me.
It's like $100 test.
It's
That's
$100
the thing that
test,
it's totally
right.
frustrating for me is,
Right.
let's talk about, resources. This is something that is accessible to most, if not all people, and yet we're still doing what I consider to be in many instances testing that's not nearly as effective or diagnostic or sensitive.
Yeah. And I think the reason for this is because a lot of medical guidelines are passed down to what works at a population level, right? At a population level, yes, we can get LDL levels on people. That's not too expensive for the nation. That's not too hard for the nation to do. But it is harder to get a CAC score because you have to go into a CAT scanner for 10, 15 minutes, right?
Yep.
That's much less accessible. We're not going to be able to screen the entire population with that because we just don't have those resources. However, I think if you are someone that has some resources, it shouldn't be completely hid from you as though something that you should never even consider, right? And so I think that's something to take into account. And LDL scores as well. I think that we've had these cholesterol panels for decades, and only recently have we upgraded to what I consider we should even just stop looking at LDL. I just look at ApoB and Lp(a) now. Those are the two indicators that I look at. And what's incredibly surprising to me is 90% of the people I see in my practice here have never had either one of those checked, even though they're visiting their primary care doctor at age 55 for a yearly visit.
It's unbelievable. And what's interesting to me is that they're not expensive tests. So if someone's listening and they're like, oh, is this one of these integrative medicine tests? It's going to be expensive. They are very inexpensive. And what's interesting is if your Lp(a) is normal, you never have to have it tested again.
Exactly.
And I think that's what's significant. It's not I have to keep monitoring this forever and in perpetuity. Now, what I think is interesting is these conversations are so important because it could save someone's life.
Right.
Really and truly, because we know, at least for women, the number one cause of death is heart disease, not breast cancer. And it's important to screen for breast cancer, but number one reason women die, 1 in 3, is because of heart disease. Right. And we should be screening men and women earlier and younger.
Yeah, completely agree. And I feel that, unfortunately, women, for some reason, don't get screened for heart disease as much as men do.
Well, statistically, we present differently. Women generally tend to present later. We're the caretakers. We worry about everyone else and ourselves last. But women typically don't get those typical, I have crushing left chest pain. I have pain down my arm. I'm having jaw pain. I've had women that literally their only symptom has been fatigue. I had one elderly nun. She had pain in her left hand, and everyone kept working her up. They're like, "Oh, you've got cervical radiculopathy. You've got all these. You have diabetes. It has to be this." And I think that part of the impetus of why I think these conversations are so important, number one, is just to bring greater awareness that not every patient presents the same way. But women in particular, we tend to have more small vessel disease, which is the stuff that can't be stented. And so we just have to understand our physiology is a little bit different. And we know that we are largely protected until we go into menopause. That the estrogen is a very important hormone for a lot of different reasons. It's involved in immune function. It's involved in inflammation. And so helping people understand that, men may have that classic crushing chest pain symptom, and that's usually how my patients presented. Women might be totally different.
Yeah, that's such an important point for sure. So men and women in your practice, at what age do you generally start checking blood tests like ApoB, Lp(a)?
North of 40.
Yeah.
Without question, because I tell them, listen, if your Lp(a) is low, you never have to check it again. Now, apolipoprotein B, I think, is certainly one of those that I like to monitor it. And what I find is if I look at and I haven't done a study on it, but if I look at my population, watching them as they're traversing perimenopause and menopause, we know once you hit menopause and that loss of estrogen is catastrophic and drops quite substantially, all of a sudden your lipid markers may look very different.
Absolutely.
That is certainly what it happened to me. I would not have believed it if I had not seen it on myself. A significant 20 to 30% higher increase in not just total cholesterol, LDL, but looking at my ApoB, looking at my Lp(a), I was shocked.
So even your LPA went up
Yeah.
with menopause.
It was already high. It was already high. Let me be clear. It's not like it went from being low to suddenly high. It was already high to begin with.
Sure.
And it just got even a scooch worse. Like I was shocked. It was like I wouldn't have believed it had it not been on myself.
And was hormone replacement therapy helpful in reducing your lipid markers?
Yes, absolutely. Yeah. And to me, it was like the more I understood about the role of estrogen, and certainly now after writing a book that I spent a whole chapter talking about immune function and sex hormones, I'm like, holy cow, now it makes so much more sense. So this is one of many reasons of why I think HRT and bioidentical hormones can be really an important conversation to be had, not just for women, but also for men as well.
Absolutely. Absolutely. And I think, the more conversations I have around this, you just realize more and more how integrated everything really is. We would never talk about hormone replacement therapy in relationship to cardiac risk, right? And now, for me, it's a conversation I have all the time because they are definitely intertwined.
Well, I think I'm almost embarrassed sometimes when I'm talking to patients and I'm like, oh, the reason why I saw so many elderly women with atrial fibrillation, that's estrogen. Estrogen, low estrogen is driving your propensity, your likelihood of developing atrial fibrillation. And I thought to myself, we were never talking about sex hormones in cardiology, ever. Certainly not in my practice.
Right.
And this is a very well-regarded, well-respected practice. It's just we tend to be very siloed in medicine that we're like, oh, those sex hormones thing, that's a GYN problem. That's not a cardiology problem. They're like, no, we have a systemic estrogen deficiency that is impacting every single system in the body. Yeah. That if we would look at things from that lens, that makes a great deal more sense.
Absolutely. And I think, just even going through medical school and then training by myself, I could see why the cardiologist would not want to talk about hormones. It's just because you stop your hormone education your last year of medical school. You stop talking about it, right? Then you start going into internal medicine, cardiology, and it's hard to remember what you learned 20 years ago about hormones. And then what do? You refer the woman sometimes to an OBGYN or the man to an endocrinologist, and they're mostly treating hormonal disease. They're treating thyroid cancers, for example. They're not treating day-to-day hormone deficiencies. And so it completely misses the boat in Western medicine of hormone replacement therapy.
Well, and it makes me laugh because I have two good friends who are endocrinologists and all they treat is diabetes and thyroid issues. That is it.
That's it.
They're like, every once in a while we get a unicorn case, we get some really unusual case, but like that is our bread and butter.
Right.
And I'm like, that's great. But I agree with you that I was oftentimes admonished, especially when I was a new nurse practitioner, that I would sometimes, a patient would share something. I'm like, oh, well, we need to call urology. And they were like, Cynthia, stop talking to the patient about anything that is not cardiac related. But now realizing it's all cardiac related, like everything begets everything.
Exactly. It's so true. So let's talk about menopause. Why do you think for so long, it's kind of a little bit of a rhetorical question, but why do you think for so long women have not talked about menopause?
Oh, I think it is... certainly, I think that there is a lot of shame and a lot of grief for women as they're navigating the loss of fertility. I think that's part of it. Certainly when I think about my mother's generation, my mother never had a conversation. My mother was a nurse, never had a conversation. None of my aunts or grandparents ever talked to me about menopause. I think women were expected to suffer in silence. And I feel like I've interviewed enough physicians now on the podcast that have said that to me, that I have to agree that I think there's been this prevailing thought process of you're eventually going to go through this and you're going to just suck it up and white knuckle it. And since the Women's Health Initiative, you don't get hormones because they're going to cause cancer. And so you just suck it up and accept it. And so I think that there's both a shared fear of women aging. That's number one. I think there's, again, a lot of shame and secrecy around the aging process. Because I think even now, even with as progressive as I think we have gotten comparatively to probably our parents' generation, I still think there are women that don't want to admit, like, I'm no longer fertile. I no longer get periods. It's like saying that is like the big elephant in the room. And I hope that this destigmatization continues, because it is so critically important that women are speaking up and speaking out, because in many instances, sharing our stories allows other women to talk about their stories and to normalize it. But I think in many ways, it starts when teenagers start menstruating or young women start menstruating. It's like fear and shame around period products and tampons and period underwear and contraception. It's like everything that evolves around sexuality is taboo. And I think the only way to move beyond that is to continue having conversations where people can openly discuss their experiences and not in a way where we are suppressing women's experiences.
Right.
I think that that is very important. And when I talk to aunts of mine who are obviously now menopausal, they'll say, well, no one talked about it. Like I was told I was given an antidepressant. Because I had vasomotor symptoms. I was told that I was becoming diabetic, with no one saying, well, you're becoming diabetic partly because you've lost this estrogen signaling. Right. The brain fog, oh, you just need to sleep more, or here's another antidepressant. So I think in many ways we have convinced women that their suffering is part of the process instead of saying, okay, what you're experiencing is real and let's figure out a way to make it better. Yeah. And so I think in many ways it's multifactorial. I think there's a lot of reasons that have contributed to it, but I'm hopeful that, our generation is changing the narrative.
Right. Yeah, it's finally happening. I feel like it, but sadly, it takes a long time for the information to spread, but thank goodness for podcasts because things are spreading a lot more quickly now. And thank you for coming on this one to talk about this.
Yeah, absolutely. But I think, and I'll be honest with you, there was a period of time. So in 2019, I was hospitalized for 13 days and I was actually quite sick. I had a ruptured appendix and got septic and got very sick. And you can imagine as a surgeon how sick a ruptured appendix can be. I had a slew of complications. And I never had a period again because I lost 15 pounds and I'm not a big person. So that was the end of my, that was the beginning of the end of my fertile years. And so, I think there was probably 2 years after I was officially in menopause. I didn't want to talk about it. And I kept saying like, what, why am I not talking? I'm a nurse practitioner. Why am I not talking about it? And so I do understand how women can feel a sense of stigma and shame around that aging piece.
Right.
Although now I look back and I'm like, that was so silly. Like, why would I even waste emotional energy about talking about something that's going to happen if we live long enough?
Right.
And especially because, I didn't expect to go into menopause at 48, but it was hastened by this pesky appendix that created so many problems. But with that being said, I think for a lot of people, it is societal conditioning to, kind of de-emphasize your experience, to kind of nullify your experience. And when I say this, I'm not saying that everyone behaves this way, but if I look at it as a broad contexture, like women aren't supposed to age, like women are given this kind of a lot of powerful messaging. Whether it's the filters on social media, whether it's stuff that we see on TV or in movies or print ads, if anyone even still reads magazines, or stuff that we just see in general. I think I think people can be cruel and can be mean. And it's like I sometimes will say to my husband, I'm a huge introvert, and I sometimes just love to observe people's behavior. And I'm like, men in many ways, if I look at comments across social media, men can get away with quite a bit. But you'll see a woman who's naturally aging, and in many instances, people will make comments about it. And I'm like, this is why women are afraid to talk about these things. And yet it must be talked about. Right. It's so important that we talk about it.
Absolutely. So in your practice, what do you consider the state of the art now for hormone care? Let's just call it hormone care to start with, and then we'll talk about hormone replacement therapy. But how do you start someone on this journey? I assume women are coming to you, maybe they're in their late 30s or even early 40s, and they're saying, I feel like maybe I'm experiencing some of the symptoms of perimenopause. How do you start them on this evaluation and treatment process?
Yeah, I would say, symptoms guide everything, really and truly. You can look at lab work, and I know this can be very controversial. The traditional allopathic model says, what's the point of looking at, sex hormones? There's no need to do that. I'm a data person, so I do like to look at labs. And I like to have something objective to say, okay, we just did this salivary cortisol distribution over 24-hour salivary cortisol, looking at data points. And I can see where you're really tired because, you don't have a robust, circadian rhythms should follow a typical kind of pattern. It increases 1 to 2 hours after awakening and then ebbs and flows throughout the day and is lowest at night, ideally. And so I can sometimes back it up and say, well, it makes sense why you're exhausted, because it's not flatline like I'm worried they have Cushing's, but it's or Addison's rather. It's flat. It's evident to me that there's something quite significant going on. And looking at lab work, we can look at trends over time, and I think that can be helpful. So taking a really good history, which I think is the number one biggest, most important thing you can do. Looking at symptoms and looking objectively, like talk to me about your sleep, because I tell everyone if I can't get you to sleep through the night, that's number one, the biggest thing that I have to worry about first. Really looking at like, what are you eating? And I always tell people, like, don't tell me what you think I want to see. Like, I actually need to understand, what are you eating? Because most adults are consuming ultra-processed foods. I think it's 70%. I think Sean Stevenson mentioned that last time he was on the podcast. 70% of us, that's the bulk of our diet is ultra-processed foods, which we know not only does it dysregulate hormones, but also encourages us to eat 500 to 1,000 calories more. And that's just per day. So over time, that's quite a bit. Looking at how they manage their stress. And what I find is most 40-year-olds, they're not managing their stress. They think it's 5 minutes of meditation once a week, helping them understand, like, it does need to be a proactive practice, like something we're doing every day. And then the other piece is, really looking at, like, what type of exercise are you doing? Because my whole generation, our generation, has been conditioned that cardio is king. And helping people understand, like, that loss of muscle mass as we are navigating our 40s into our 50s is catastrophic for insulin sensitivity. And so helping them kind of re-engineer those lifestyle pieces is a starting point, along with testing. I am a fan of testing. I like to look at a lot of different things, whether it's a NutriEval looking at micronutrient deficiencies, whether it's looking at a Dutch test to look at estrogen metabolism, whether it is looking at stool testing, which I do on everyone. And I tell everyone, I'm like, before we do any other fancy tests, I want to know what's going on with the gut biomarkers. And then, looking at other types of serum labs, blood testing labs to see what might be going on. But that is like a very kind of cursory perspective. I think that, I would be nowhere without the health coaches on my team, because they fill in the conceptual gaps in terms of information, and every woman might need support in different ways. But usually people are coming, it's always weight loss resistance. That is the impetus for people trying to figure out what's going on. It may not be the brain fog. It may not be the forgetting the word in the middle of a sentence. It may not be that they have no libido. But the weight loss resistance is usually the biggest pain point, because they're like, I've done everything that I could imagine to fix this problem, and it's not fixable. Like, what I used to do no longer works. And so the weight loss resistance piece is usually the biggest question that they have, like, why am I weight loss resistant? Why is this happening? But that's a starting point. Now, for you with your male and female population, are you, I know this question, I know the answer to this question without even asking it, but I would imagine you're doing quite a bit of diagnostic testing. You're offering that to your patients.
Right, yeah, and for multiple reasons, not just for menopause or andropause. We're doing it because we want a full picture of what's happening. But, totally aligned with you on the testing. I think that it's so critical to have the testing, because I think that symptoms are great to follow. And I obviously follow symptoms, especially when it comes to hormone replacement therapy. But I also find that symptoms are very lagging in a lot of disease processes to what's actually going on in the blood work. So you can detect things 20, 30 years before they actually manifest themselves. And metabolic disease, obviously, we know is a huge culprit there. I'm a big fan of Dutch testing as well. Could you just describe in your own words the difference between Dutch testing, what it is, and blood testing?
Yeah, so I like to use both the urine and the saliva when I do the Dutch. So there's different types of Dutches, and this test can be controversial. There are people that think it's pseudoscience. I find it valuable because it allows me to look at both urinary and cortisol and saliva metabolites for cortisol and DHEA as a starting point. It allows me to get a snapshot test of looking at metabolites for estrogen, looking at how you break it down. There's preferential pathways for estrogen metabolism. It allows me to look at byproducts of testosterone metabolism. It allows me to look at progesterone, although I don't find that to be a super valuable test for progesterone, and I always tell my patients that up front. It allows me to look at oats, so the organic acid, looking at metabolites for certain neurotransmitters. It can, I can look at melatonin, and it's a really unique and novel. And I'm a huge believer in that melatonin is, as I know you are, is more than just a sleep hormone.
Right.
It is a master antioxidant in the body. So it gives me kind of a gestalt
Right.
of a place to kind of look at, like, what are the things we need to do? As an example, if your estrogen metabolites are not going down a favorable pathway, it's like, okay, is there genetics involved?
Yeah.
Are there lifestyle things that we need to do to better support this? It can also allow me to see, if you've got, again, it could be genetics, phase 1, phase 2, detoxification effects. And so, like, I'm someone that has the MTHFR mutation, so I always need phase 2 detox support. And that always shows up. I mean, it's a pretty consistent thing. So for me, it allows me to personalize and kind of tailor what I'm doing. But the Dutch can be done in different ways. It can be done on men and women. There are, you can do cycle mapping, which I don't do much of because most of my women are kind of towards the end of their fertile years. But you can look, I think, rather persuasively and objectively at other data points. And for me, the value of doing the Dutch is really getting that distribution of cortisol. For me, that's why I really like it. Looking at estrogen metabolism in particular, looking at the phase 1, phase 2, and then making decisions. Like for me, many times the information that I receive can actually point me down a direction. Is there a genetic SNP that's contributing to why we're seeing very low testosterone in an otherwise, very young woman? And that's been an interesting thing to learn about as a provider. It's like, oh, okay, well, there's definitely some SNPs that can contribute to this. And so for me, it's a test that I like to offer, but I always explain the limitations, that it's not the same per se as looking at serum blood for specific markers. That to me, it's one of many detective tools that I can use to decide, okay, what direction do we want to go down? Now, one thing that I always say is that if you are doing a Dutch with a provider, make sure it's actually someone who's looked at a lot of them, because it is quite a complicated test. And sometimes I actually get referrals from other providers who say, I ran this test on my patient. I have no idea how to interpret it. Would you mind taking a look at it and giving me some perspective? So it's definitely not an uncomplicated test.
Right. It's pretty complex, and you need to have some experience reading it for sure. But definitely, obviously, we're all checking blood markers of estrogen, progesterone, testosterone, total testosterone, hormone binding globulins. I think those are all kind of where we start. And then when do you start someone, or let me ask you before that, is every woman a candidate for hormone replacement therapy?
I think it is. Every individual is worth having a conversation around it. It's informed consent.
Right.
Certainly there are people that are at higher risk for having problems than others. And so it's really sitting down and having a conversation. I met someone recently who had a history of DVTs. And, it's like having that conversation. Okay, maybe transdermal estrogen is appropriate for you, but I would never give you oral estrogen, and here's why. And so I think there's very few people that it's not appropriate for. I use the example of vaginal estrogen should be given to everyone. You and I have seen over the years of working in hospitals what happens when women don't have enough adequate estrogen and develop urosepsis, and in many instances get very sick, end up in the ICU, and in some instances can die, and that can be largely preventable. So vaginal estrogen is a yes for most, if not all, and I like to compound it so that they get more than just estrogen. When I think about conversations around transdermal delivery systems for most of these drugs, I think that makes things less likely to have side effects. It doesn't mean it's impossible not to. When I think about who's appropriate, who's not, it's really sitting down and it's like, what's your personal history? What's your family history? What are the things you're concerned about? What are the symptoms that are really bothersome? How can we help avoid them? I think that, one thing that I found that's been really interesting is that pregnenolone is this memory hormone that I test on everyone. And most women are really worried about cognitive decline. And so pregnenolone is not per se something you have to have compounded. There's actually supplements over the counter, just like DHEA. And hopefully, cross my fingers, that won't change anytime soon because it makes it pretty affordable for people. But kind of looking at those different variables to determine what makes the most sense. But I think when we're talking to women in perimenopause and menopause, it is driven by symptoms. It is driven by their goals. It is informed consent, so they understand the potential side effects of anything that you're prescribing. And I think most of us are doing that. But the other side of it is helping them understand that interrelationship with, thyroid. How many patients are you having to address thyroid? And not making people feel like there's something wrong with them if their thyroid suddenly lags and they, whether it's latent Hashimoto's or Graves' disease, helping them understand that part of that complex hormonal replenishment is looking at thyroid, looking at adrenals, making sure that it's not just narrowly focused on sex hormones, but thinking comprehensively, I think is very, very important. But I would say informed consent is the most important thing, and really getting clear. Some people are like, I'm not ready to dip my toe in the pond totally. Right. Maybe I just want some compounded progesterone to start. And that's what I'm willing to do. I have a lot of women that are fearful to start estrogen because they think they're going to gain weight. They're fearful to start testosterone because they're fearful that they're going to have, too much androgenic stimulation.
Right.
And then just helping them understand that when HRT is dosed appropriately, the side effects should be minimal to none. That is what we all aim for. Right. I think there are certainly practitioners out there that think differently and want to, they want to go different routes of administration that are more likely to have significant peaks and troughs that can, develop more side effects than when I tend to be more conservative. And I think that's where my comfort level lies.
Yeah, no, that's fantastic. And, one of the questions we get all the time is I have a history of breast cancer in my family. Am I not a candidate for hormone replacement therapy? How do you answer that question?
Well, we always go back to the informed consent.
Right.
I always pull out Avram Bluming and Carol Tavris' book, Why Estrogen Matters, and help them understand, this is a process in which the information from the WHI was misinterpreted in many instances, and helping them understand that just because you have a family history of breast cancer, there's genetics that we can look at, genetic markers, that's number one. In the absence of you having an increased risk based on genetics, it's, let's take this low and slow and make sure that, the nutrition, the lifestyle, detoxification pathways are all optimized so that we're less likely to develop that. And it's interesting because I don't know if you're familiar with Avram's work, but he's an oncologist, and he talks about how his wife and his daughter both had breast cancer. He felt strongly that his wife's circumstance, because she was menopausal, was probably in a low estrogen state, more likely to develop this particular type of breast cancer. So I always remind women that there is research that is coming out that is suggestive that, if estrogen caused breast cancer in most instances, then we would be seeing a lot of younger women with breast cancer. And I'm not suggesting that doesn't happen, but that is less common. But it's really this low estrogen state that can stimulate this proliferation of malignant cells. And so number one is informed consent. Number two is doing the genetics. Number three is seeing what does this patient want to do?
Sure.
And I find in most instances, careful monitoring, whether it's breast cancer, endometrial cancer, uterine cancer, just, making sure they're getting their annual Pap exams, making sure that they're not missing opportunities to screen. And obviously mammography is coming up as being, one of these screening tools that the more information that's coming out is suggesting that there's other modalities to monitor and evaluate breast tissue, like QT imaging as an example.
Right.
I'm not sure if you're familiar with Dr. Jen Simmons's.
I just saw something come through my desk on the new machine. Is that what you're talking about?
Yep. Yeah. Where they're examining breast tissue, and she was a breast cancer surgeon for years and years and years. And so I think inviting those conversations to say, there's no perfect screening tool, but we know that lifestyle plays a huge and enormous role in cancer risk. And so dialing in on all the things that we've kind of alluded to can be very helpful.
Yeah, absolutely. On the QT scanner, talk about that a little bit.
So I just know the basics.
Yeah.
Dr. Simmons has been a guest on the podcast twice. It's ultrasound, but it's actually more sensitive and specific than MRI or mammography without all the radiation. I mean, your breasts are actually in a sound bath. I mean, there's real science behind it. Right. I started explaining it out loud. People are like, what? But it's apparently it's supposed to be more diagnostic, less radiation, because one of the things that Dr. Simmons talks about is that this cumulative radiation of the breast tissue over time can be problematic for potentially injuring tissue. And so, her biggest thing has been, what is something that we can do that is less invasive, more diagnostic, hopefully will be eventually covered by insurance. But, a lot of insurers, they want to, they want their way or no way. But with that being said, I understand just the bare bone basics. I don't even understand all the physics involved, but
Right.
Now I'm gonna endeavor to learn more so that I can speak more openly
Yeah, it
about
could be a game changer because it also looks a lot more comfortable as
Right.
far as a test goes too.
Yeah, mammography screening is not fun.
Exactly. And, there's I've always wondered, I did a lot of breast cancer surgery when I did surgery and reconstruction as well, removing tumors and then reconstructing. And I always wondered, when you're doing a mammogram and you're putting the breast in between two plates, you're causing a lot of damage and you're concentrating the radiation exposure into that much smaller area to tissue that's being actively damaged. Those multiple insults at the same time cause a regenerative response that can't be a good thing over and over again, year after year, especially if you're one of these women that need special views done of a certain area. So I've always been a little bit suspect of mammography, and I'm not telling women to stop getting mammograms at all. Keep getting mammograms. It's the best thing we have right now, combined with maybe an every other year MRI. However, I'm really excited about new imaging technology because I think it's really needed now.
Absolutely. And I think there are a lot of people who are scared and worried about breast tissue. And certainly I personally have 3 or 4 girlfriends who are all super healthy, all developed, breast cancer and, went through a lot of surgery, a lot of radiation, chemotherapy, et cetera. And so in no way am I suggesting that screening's not important. I think we're starting to just learn that there are other options that may be more diagnostic and less likely to cause issues. What's interesting is every time I get and I usually do it every 3 years because that's what I was comfortable with. And I'm looking at the PSI, the pounds per square inch that are coming down on the breast tissue and me holding my breath the entire time and just cannot wait for it to be over. But I mean, it is painful. And I think for a lot of women, it's one of those things much like anything in life. It's like you just kind of look at it just like getting your teeth clean, go to the GYN. It's like just one of these things you have to do. But I'm excited that there might be technology that's going to help women and be able to do it in a way that's much less painful.
Yeah, absolutely. You mentioned genetic testing. Are you talking about the BRCA gene test?
Yes.
Okay, great.
Yeah.
Any others?
Not for me. I mean, if I have a high index of suspicion, I have colleagues that I'll refer out to when I feel like this is not my area of expertise. If I feel like there's something, if someone has a unique genetic kind of makeup, I use the BRCA screening, but it's interesting to me how many people will say, oh, I've got a lot of uterine cancer in my family, endometrial cancer, colon cancer, colorectal cancer. I'm like, you're someone that I would feel most comfortable that you see someone that is very specialized to get their feedback before we do anything. Right. And again, I think it just harkens back to, just being that conservative nature. I'm never going to be the person that's, I'm never going to be the person that's kind of, cavalier about hormones.
Sure.
It's just not my comfort level. And I'd be the first person to say, as a nurse practitioner at a time when I became an NP in the early 2000s and there weren't as many of us. And I remember I felt like I had to take the extra due diligence in everything I did because our training is so different.
Right.
And I remember saying that to a colleague of mine, a physician colleague, and he said, oh, I totally agree with you. And so I would say I'm probably a little more conservative than maybe other people are being. I'll give you an example. So I'm licensed in the state of Virginia. Occasionally women will come through programs and they're in a group program. And we can facilitate a lot of things in a group program, but if they need hormones, referring them to someone in their state. And so now there are a lot of telemedicine options.
I know.
And there have been a couple hiccups that have made me realize there are certain companies that are not in alignment with the way that I think. And I would have women, I would say to this, I would make a referral. I would say this patient I think needs thyroid replacement, maybe some progesterone. They always got put on testosterone. I know it's always injectable. And they came back to me. They had acne and their hair's falling. And they're so mad. And they're like, I know you didn't do this, but what's happening? And I'm like, this is a great example of, route of delivery is important, too high of a dose. And then I'm feeling, it's like I'm going to always be that reformed people pleaser, that immense guilt of if you lived in my state, we could have gone a completely different direction. Yeah. But with that being said, I think anytime we're doing telemedicine, there's a lot of great companies doing great things, but there's also a few out there that, are prescribing much higher doses than what I would feel comfortable with starting a patient at, or just completely negating the need for thyroid replacement when clearly they need thyroid replacement, and are just focusing on maybe 2 or 3 sex hormones, and that's all that they're talking to the patients about, which I think does them a disservice. And they're paying a lot for these medications they're getting too.
Yeah, I agree. And I see this over and over again. I mean, this is ubiquitous in men's health, especially. You get an online blood test for just the total testosterone level, and then they just send you hormones and you don't even talk to anybody. And what you're missing there is the big picture, right? You're missing what is the metabolic health of this person? What is the inflammation levels of this person? What are the other disease processes going on at the same time? If you're going to an online hormone center or getting your hormones online and they're not looking at all of your biomarkers and they're just focusing on a few, that's a red flag in my opinion.
Yeah, no, and it's interesting because even I was having a conversation with my husband and I said, the main reasons why men have low testosterone right now is exposure to mycoplastics, so, estrogen mimicking chemicals. Number 2 is insulin resistance. Right. So if someone's prescribing you testosterone without addressing those 2 issues or at least having a conversation around it, that's a huge red flag. Yeah. And I have to believe that most telemed people are endeavoring to do what's right for the patient. But I do think there are some bad apples, and that's on the women's health side as well. Like there's someone that will remain nameless that I interacted with when I first started hormone replacement therapy, and it was clear to me within like 2 months that this was not a good fit for me. And this individual is still practicing, and I just kind of hold my breath. I'm like, but how many people don't know better?
Right.
Like for me, I knew very quickly something was not right. But even with proper vetting, sometimes you can end up in the hands of someone that's not a good fit for you.
Right. And so your preferred route of delivery for women is a transdermal
as
cream
a starting point
for estrogen, testosterone, vaginal estrogen, and then progesterone obviously is a tablet. So that's how you like to start women because you have less complications.
Yeah, I mean, and I'll be honest. I mean, I like an estrogen patch. I think, I'm someone that was using compounded estrogen for like 2 years. I just wasn't absorbing it well. And so I finally got to a point, now I'm on an estrogen patch. I absorb it really well. And so I think for as bio-individual as we are, as we navigate middle age, men and women, each one of us might need a slightly augmented regimen. And so I think estrogen is great. I think for some women, they need not just also vaginal estrogen. Some of them need DHEA and or testosterone because we know that can be very helpful for the muscular layer in the vaginal walls, and not just estrogen is also very important. I find for a lot of people, I have women who are fearful to take estrogen. They're like, I just want the testosterone. I just want the progesterone. And so it's helping them understand, like, what does the research show? What is beneficial? Again, that cognitive function is something that a lot of women get concerned about. And I'm like, I get that. I never want to be a burden to my family. In fact, I jokingly tell my husband, I slap that patch on twice a week because I know I'm like doing the right thing and making adjustments as we need to. Progesterone, I think, is interesting. Micronized progesterone you can buy very inexpensively. It is immediate release, not sustained release. I find a lot of women do better with sustained release formulations that help with the sleep piece. Testosterone, not everyone needs testosterone. And I know people are surprised. I think it's about 25% of women in menopause still make plenty of testosterone. I was not one of them. I think testosterone is super important, not just for people think about it just solely from the lens of libido, but I always think about testosterone from executive function. It's the get off the couch and get moving. It is, helpful for muscle, which is so precious and hard to build at this stage of life. Right. I'm just not one of those people that wakes up in the morning and I'm instantly buffed. I am going to have to lift heavy for the rest of my life to maintain my muscle mass.
What do you think about pellet therapy for estrogen and or testosterone for women?
Well, I would say as a whole, I think pellet therapy can provide super therapeutic levels of hormones. Do I have a couple colleagues that I think probably are pretty conservative and do a nice job? Yes, because we've had conversations about that. I think the vast majority of these pellet factories, pellet mills, people might feel good initially and then they don't. And the problem is once it's inserted underneath the skin, you are left with that for 90 to 120 days. And so I think that I think it's controversial. I personally haven't had a patient that's done well on them. I think people that gravitate towards me are very likely individuals that are looking for a more conservative approach. But I understand. I mean, it makes sense. Like, wouldn't it be great if we just inject a little grain, it's like the size of a grain of rice, underneath the skin, and it delivers hormones for 3 months and we don't have to think about it again? It's incredibly expensive. I think that I think some women start doing it and then they realize it's incredibly expensive, and that's a whole other issue. I had one woman that was in a program that said, I know my testosterone's low. My testosterone is definitely low because I can feel it. Turned out it wasn't her testosterone, it was her cortisol was low. Her testosterone was actually super physiologic. And in fact, so high, it was like the value I would expect a male, an adult male to be within that range. I've certainly seen a lot of reports of women that are having MIs because they're myocardial infarctions, heart attacks, because their testosterone is super therapeutic. So I think in a very capable conservative hands, maybe pellet therapy. That's not what I subscribe to. But I do think the vast majority of people are significantly super physiologically dosed. I know that's the point of them anyway, but it puts them at a level that, if they have a side effect or a problem, there's nothing you can do about it.
Yeah, because it's in there already. Yeah. We have all the options at our clinic. And what normally happens, men do pretty well on pellet therapy. Women, we always start with creams first and patches. And then if we're kind of like at a real stable dose, then we mimic that dose in the pellet.
That's what I'm saying. So like in
super conservative.
In the hands of a conservative provider, probably great. But I think a lot of people shoot really high.
Yeah, that's the problem. And we don't like to make anyone super, super physiologic. It's just not. It doesn't lead to anything good in the long term.
No, I actually have a colleague that was given a male dose accidentally.
Oh, no.
And she had every side effect you can imagine. Her voice changed. She had clitoromegaly. Obviously, a very litigious situation because that was like a grievous error. Like, not only did you get you got a male dose of a pellet.
That's really hard to do because you have to put in a lot of pellets to get a male dose. So it was someone that obviously did not know what they were doing.
No. So that's why I was saying, like, I think there are definitely providers out there that do a great job, and it sounds like you're, very judicious and conservative, and that is different. And so I never want to say like absolutely positively no. It's just this is my comfort level, and I'll leave the pellets for the conservative, judicious, careful, conscientious providers to do.
Right, and it does take. Especially for women, it takes some time to figure out the right dosing, and it's so much easier to do with cream and patches, for sure.
Yeah, and it's interesting to me, and my team this morning were sending me questions that were being asked. We had a post on testosterone, and so everyone wants to know, what's the therapeutic range? What are you shooting for? And so I was like, we'll answer this at a later date because I was like, my team could spend the whole day responding to that. I think part of the interest around testosterone is twofold. Number one, I think women are curious because right now there's no FDA-approved form of it, which is criminal. And number two, I think that there's a lot of there's a lack of consensus right now about what is therapeutic for women. And so I think that, whether you go based on symptoms, whether you go based on ranges, I think it depends on the provider what the answer might be. But I think more often than not, like a patient's symptoms should really guide therapy as opposed to getting very rigid. Like, if your free testosterone is outside this reference range, then there's something wrong.
Yeah, I agree with you. We always go based on symptoms more than anything. You mentioned the Women's Health Initiative a couple of times, and I was in medical school when the Women's Health Initiative came out, and we were obviously taught that hormones cause cancer, do not give them. And so now we know that was a misinterpretation of the results. There was also a lot of reasons behind that misinterpretation, et cetera. And you can read a lot about that in the book you talked about earlier. But, what's happened is we have 2 generations of women now that have missed out on hormone replacement therapy. And sadly, it's still happening. There's going to be a 3rd generation, I feel. And we often get women in our clinic that are in their 50s and 60s that start asking after they've heard this podcast, and maybe your podcast, they say, like, am I a candidate for hormone replacement therapy? What's your opinion on that?
Oh, I think it's very bio-individual. And again, it's the shared consent. It's, what's your history? What's your family history? What's your lifestyle like? What are your goals? I think Kelly Casperson, she's a urologist, but she talks about vaginal estrogen for everyone at any time. And so I think if someone's just looking for genitourinary support, maybe it's just vaginal estrogen, and that could be prescribed very inexpensively. I think when you're looking at women that are 10 years out, it's really doing a really good cardiovascular risk evaluation. And by that, I mean all the tests that we kind of alluded to, both diagnostic and serum lab testing, and then sitting down and having a conversation and saying, we may need to clean these couple of things up first before we consider progesterone. I don't really worry about. I think estrogen is the one hormone that I think a lot of people get concerned about. Even transdermal estrogen is not going to give you super physiologic doses of estrogen. I think if someone was talking about oral estrogen therapy, that might invite let's do a hematologic, let's make sure you aren't hypercoagulable. Especially if someone said to you, like, I threw a clot when I was pregnant, I threw a clot when I was on birth control. Then I'm like, okay, huge red flag. Okay, we need to really evaluate this very carefully. I think the answer is never no.
Right.
I think that it's all about informed consent, and it's making sure everything's documented. You had the conversation, you understand, you're 10 years into menopause, and is the potentiality there that you could break off a piece of plaque in an artery if we start some estrogen? I think if you're conservative, the statistical likelihood is probably slim to none.
Right.
But the benefits are so substantial.
Right.
I really think a lot about my mom's generation, and it makes me sad because how many of my aunts were taken off of HRT in the early 2000s. And, in many instances, and they talk very openly, they're like, please talk about us. Please educate your community. Please share the things we've experienced between the neurocognitive issues, the osteoarthritis pain, the chronic fatigue. I mean, all those things that they experience. And these are healthy women that are active and doing a lot of the right things. And so, from my perspective, the Women's Health Initiative will go down as one of the greatest debacles, because of the impetus, because you have a whole generations of clinicians fearful to prescribe hormones, generations fearful to take hormones. And then, we're trying to bring things back around to explain about the limitations of the study and how they use people that were not healthy to begin with, that were 10 years into menopause and former smokers, obese, hypertensive. It's that's not the population to use for the study.
Right.
So I think in many ways, we're circling ourselves back to, a bit of science and talking to patients about informed consent. You'll hear me say that over and over and over again, but irrespective, even when I worked in cardiology, it was all about informed consent. Here's the pros, cons. Let's make a shared decision. What are you comfortable doing? What are you not comfortable doing?
Yeah. I came from surgery and it's all about the consent form. So I know exactly what you're talking about.
It's in my sleep for the rest of my life. It's that you think you get called in the middle of the night, you didn't get the patient to sign the consent form.
Exactly.
You never want to be that clinician.
Exactly. Yeah, I asked that question because I think it's important, because I think a lot of times I talk to women about hormone replacement therapy in their 60s or in late 50s, and they say, well, my doctor said it's too late for me. I've been in menopause for 10 years. I can't do it anymore.
Doesn't that break your heart?
It does. And I say, that's not true. Let's do a full risk assessment. Let's look at your metabolic health. Let's look at your cardiac health and your neurocognitive. And I can guarantee you're going to feel better most times, And so I think that for any women that are listening to this, even if you're in that age group, it can still be a viable option for you.
And we've found providers all over the United States for women that are in programs. I mean, I'm not exaggerating when I tell you, I don't even worry about it anymore. I just say, I know we're going to refer you to XYZ. And I even interviewed a guest recently who said, after we were done recording, I mentioned my mom is 79 and how she started HRT and then was taken off. He goes, I think you just need to go visit her and slap a couple patches on her. And I just looked at him and I was like, seriously? And he goes, yeah. He's like, just slap a couple patches on her. And I was like, okay. But I thought it was so funny. He's just go slap a couple patches on her. She'll be fine.
At the end of the day, that's what she needs.
Right,
exactly. An estrogen patch.
Exactly. But I was just like, okay.
So funny. So let me move on to metabolic health. So, and this is a rhetorical question, of course. Do you think that we should start thinking about metabolic health once we get diagnosed with diabetes, or should we be looking at things earlier?
Well, I remember in 2002, I was talking to a postdoc from Australia. He was an MD, PhD. This is in 2002, and he said, Cynthia, I don't know what's wrong with you all in the United States. You guys wait until people get diabetes.
Yeah.
So I can assure you that I am so proactive about helping patients avoid ever developing prediabetes or diabetes, because I think that if you look at the research on what diabetes does to our risk factors for just about everything, atherosclerotic cardiovascular disease, stroke risk, cancer risk, et cetera, you should avoid diabetes like your life depends on it because it does. So
And just on that real quick, it's not like a switch is turned on all of a sudden when you get diagnosed with diabetes. Now your risk factors start going up.
It's been that way.
The entire time you're developing diabetes, you're increasing your risk of everything else.
Yeah.
Sorry to interrupt you, but I think it's important to mention.
No. And here's the thing. Like if you wait until your fasting glucose is 95, 98, 102 to intervene, you're already there.
Right.
Like I think it was Robert Lustig that said on my podcast, when your fasting glucose is between 90 to 99, you are at 30% greater likelihood of developing diabetes. Yeah. So that's not normal. And what do? I actually get chills thinking about it. What do? We wait till our patients have full-blown diabetes before we intervene. So fasting insulin's important, uric acid's important. A1C, do I put a lot of like credence in that? I think it could be valuable, but that to me is certainly not as important as HDL to triglyceride ratio, super important. Your waist to hip ratio, super important. What a lot of people fail to recognize is there's many different things that start to happen as your fasting insulin is worsening. And, it could be something like your blood pressure starts to fluctuate a bit. It could be that you're getting more frequent urinary tract infections. I mean, there's so many things that we just don't think about as a like whole constellation. And then just forget about navigating perimenopause. I mean, that you're losing insulin sensitivity just like you're losing muscle mass. And all these things coming together are like the perfect toxic brew for developing diabetes if you don't work against it. So I'm a huge proponent of glucometers. I'm a huge proponent of continuous glucose monitors. I am very proactive. I have one woman that was unwilling to go on medication, and we tried everything. I mean, when I tell you everything, berberine, myoinositol. I mean, we tried everything. We even got her on metformin. She didn't tolerate that. Finally, I was like, I think we have to talk about a GLP-1. And it took her a month. And then she was finally ready. And now finally, like I'm starting to see fasting blood sugars in the 80s. But I mean, it was like, for like 2 years, she was not willing to accept. I was like, you are declaring yourself. You are there. It is time to get proactive. And on the GLP-1, she tolerates it beautifully. She's on a very low dose of tirzepatide. It's unbelievable. I think these drugs are changing the game, changing the conversation for not just inflammation, but metabolic health in a way that is unlike anything else I've seen in my lifetime.
Exactly. And I completely agree with you. I think there's been so much media around Ozempic and celebrities taking it, and now there's shaming around Ozempic and the side effects. It's mind-blowing to me what's happened to the discourse around these medications. And everyone should know the side effects happen when you use them incorrectly.
Correct.
That's when the side effects happen, right? If you go to a provider that's judicious, conservative, and is looking at your biomarkers and following the dosing guidelines and not increasing you too rapidly, the chance of you getting side effects is almost zero from these things. And,
I agree.
Some of the side effects that people talk about, nausea and, constipation, those aren't side effects. Those are effects. Those are going to happen. You're going to get through them. But when you look at GLP-1 specifically for metabolic health, there's nothing better out there, in my opinion, right now. The SGLT2s maybe are going to help even more. These are a new class of medications that help control your blood glucose levels and your metabolic health. But GLP-1s are definitely, for me, a mainstay now in people that are struggling with their metabolic health. And we could talk about weight loss separately and completely differently, but I think metabolic health, 90% of Americans right now have some degree of metabolic health issues, and it has to be addressed because it is the root cause of almost every other problem out there.
Well, what I find really interesting, and I have a family member that is taking a GLP-1 right now, and he said to me, I didn't realize how much food noise I had. Because I had said, don't be surprised if you feel like the pantry is no longer beckoning to you at night. And that has been their greatest gift and blessing. And so it upsets me enormously when we see people with very large platforms speaking up about GLP-1s as if we are offering people poison.
Right.
When I'm like, first of all, if 90% of us are not metabolically healthy, it is a public health crisis. we need public health crisis interventions. Right. And so, from my perspective, the shaming, the blaming, the social media people that like troll to try to like, what celebrity looks like they lost a bunch of weight. I'm like, just be happy for that person. Just like, to me, I feel like it's almost like Sisyphus. It's like we're trying to like push this boulder uphill, and we're forgetting ultimately, what are we supposed to be doing as healthcare providers? First, do no harm. And so to me, if we are dealing with a crisis, a metabolic health crisis, the most important thing we can be doing is having these conversations and allowing patients to feel empowered to ask for a medication that we know may change their life in a really positive way.
Right, I agree. I think GLP-1s, if used responsibly, will unburden our healthcare system to trillions of dollars of savings if we just get our heads wrapped around using these, first of all, responsibly. Secondly, using them as an opportunity to change people's relationship with food. And I think that's where, just like with, Crestor and the statins, instead of just flinging them at people with zero advice on what to do with lifestyle, you must pair yourself, I think, with some provider, whether it be a health coach, a nutritionist. I give every patient on a GLP-1 a continuous glucose monitor and a nutritionist consult. I think those two go hand in hand. You can change your relationship with food, which will eventually lead to maybe you don't need the GLP-1 anymore. But let's at least get your metabolic health under control, right?
No, I think it's important. I mean, the one thing I do caution people about, and I think this information is clearly getting out there to the masses. Number one, you got to eat enough protein. So even if you're eating less, you got to eat your protein. Number two, you have to strength train, because the concern is that when we're losing fat mass, we're also losing muscle mass. And we all know that that can be catastrophic if we're not actively working against it. And so I think that's the other piece that not enough people are talking about, because we've conditioned our patients. You take a pill, a potion of powder, we're going to lose weight, and then we don't have to do anything about it. It's like, let me just do this. And we're here to say these drugs are powerful, they're important, but we also have to ensure we've got, shared patient understanding that it is equally critically important that they are lifting the weights, and yes, lifting weights, and we are eating enough protein. And that might not be like every day, you may not hit your goal, but like over time, over the course of a week, very important.
Yeah, I think while you're on it, you shift your focus to a protein-first diet, and it makes a huge difference. And we also give all of our patients on GLP-1s a bioimpedance scale, because we want them to track their skeletal muscle mass over time. And I could tell you almost universally, we have patients maintain their muscle mass when they're on the GLP-1s because we're so emphatic about it, right?
Yeah, I think that the scale is really smart, because then people have an objective measure at home of like what they can look at.
Exactly. And, we can argue all day about the accuracy of these bioimpedance scales, but what I can tell you is that if you do it the same time every day, which I prefer first thing in the morning before you get in the shower or after shower, you can track the trend line, which is more important than the actual number. If you're trending downward, you need to increase protein, increase sessions at the gym, and you can head in the right direction. So that's how we manage it.
No, I think that's smart. And what's interesting is, there's like Bod Pod, there's all these, options, but like not everyone has access to that in their areas. That's number one. Number two, that might be prohibitively expensive. And so I think the other piece of, in this functional integrative medicine space is like trying to find what works for most so that it can be accessible, attainable, et cetera.
Right. And these scales are on Amazon for $20. I mean, that's very accessible, I think, for most people. And it's not to measure your weight, just to be clear. It's to measure your skeletal muscle mass and your fat mass and see which direction each one of those are trending. What's the biomarker that you use for getting people's current status of their metabolic health? What is the first biomarker that changes in that sphere?
I think fasting insulin, because I've seen people that have had a fasting insulin of 20 where I'm like, whoa, I know why you're not losing weight. With intermittent fasting and strength training, and whether plus or minus a GLP-1 changes in their diet, I mean, you could see a 50% drop in a relatively, within a 90-day period of time.
Yeah.
I do like the CGMs and glucometers because it allows them to have like, should I have eaten 60 grams of carbohydrate with my dinner because I now know what it does to my blood glucose and my excursions? I think that can also be valuable. But I would say fasting insulin is a starting point because I can see an improvement pretty consistently. Whereas if they've been insulin resistant and teetering on that for years, it may take a long time. That's where they get discouraged. They're like, why is my fasting glucose so high? I'm like, well, those cells have been, it's like, you're knocking on a door and it's like muffled. Trying to explain, like, it's taken a while for those cells to get resensitized. So, over time, I think that fasting glucose can sometimes be a source of frustration for patients, but I just explain it's just the messaging has been muffled and your cells are starting to get resensitized to this important hormone.
Yeah, I agree. And a lot of times, we measure full blood panels in all of our patients like you do, and their fasting glucose is normal, but the fasting insulin, like you said, is 20. And that's, to me, a warning sign that we're headed in that direction.
Yep.
So it's incredible to me. Almost no one, when they come in with their blood reports from their traditional primary care, has a fasting insulin level.
No,
Nobody,
they don't. And
right?
I've had physicians tell me, like, I don't know how to interpret this. I was like, let me help you. Because this is really straightforward and easy. It is not normal. Like, you don't look at the normal range from the lab.
Right.
Like, number one. Number two, this is where you want it to be optimal.
Right.
And I was like, draw them quarterly. But if you have patients that are pre-diabetic, it is criminal. Like, I think it is criminal not to be drawing them because they're inexpensive, super inexpensive. And the patient then has another objective measure. I tend to attract women that like data too. So it's not surprising that they're like data. I'm like, okay, where we were 6 months ago, where are we now? How can we kind of look at this? Looking at, like as an example, before we even have conversations around medical treatment intervention for lipids, we're looking at like the cholesterol balance test through Boston Heart. I'm like, are you a hyperabsorber? I love that test, by the way. I'm a hyperabsorber, so it makes a lot of sense. It's like, okay, why don't I do well when I eat fatty foods or like fatty meat? I'm like, oh, it's because I'm a hyperabsorber. I absorb way more than the average person. But hypersynthesizers, then talking about like what's appropriate medical therapy, like maybe you need some Zetia, which is right at the lumen of the small intestine. I'm like, that's a super easy drug. It's inexpensive. It was so expensive years ago. I remember calling my Zetia reps. I'm like, you need to drop off more samples because my patients, it's too expensive.
It's so inexpensive now. And
it's dirt cheap.
I find so many people can just take that and their ApoB goes down to an acceptable range,
I am on Zetia, and it was amazing. And it was funny, my practitioner, when we did my labs initially, he was like, oh, because initially he had prescribed me an old cholesterol drug that didn't work. Call for me. I could take 1 out of 6. I mean, it was like a joke. I'm taking a whiff of it. He goes, oh my God, you're totally a hyperabsorber. I was like, that's why I tell you, like, I'm not making this up. Right. But like my ApoB dropped to like 60 on Zetia.
I think it's important for the audience to know what we're talking about here. Some people absorb a lot more cholesterol. And your liver has a hard time metabolizing all the cholesterol, so it does actually end up in your bloodstream. The way we know that is with this special test called sterol testing. It's available on a blood panel called Boston Heart Diagnostics. So I'm a big believer of everyone that gets put on statins should also have a sterol test done because you might be able to at least reduce the dose of any other medications if you're on Zetia, which is a medication to prevent the absorption of cholesterol. So it's an extremely important point.
Well, and thank you for that. And what's interesting is I have several patients who their primary was saying, you need to be on a statin, you need to be on a statin. We ran this test, with their permission. I shared the results with their provider and I explained, this is a test I think all of us should be running before we even have a conversation about a statin. I'm not talking about a diabetic who's had a heart attack. I'm talking about other people. But in the context of that conversation, and this provider said, oh my God, I didn't know this existed. I'm now going to be ordering these. So I jokingly said to my Boston Heart rep, well, kudos to you because you're going to get more business from this person who has a very large practice. But just explaining like this is another tool in the toolbox. And I think it also reaffirms like how many of my patients who are hyperabsorbers have the same propensity of, I can't tolerate fatty meats. If I eat a lot of like fat, I feel sick. And so the hypersynthesizers, obviously a statin would be indicated, but there are other ways to address that as well. So I think that it's another valuable test that we can offer to patients to get more clarity about what they, in their own bio-individual, what their needs are.
Right, I agree. On the topic of metabolic health, you've talked a lot about intermittent fasting, and I would love to just get your most current perspective around it. There's been a lot of chatter around some people that should not be fasting, a lot of chatter around women and how it affects their hormones. Can you tell us kind of your current thought process around intermittent fasting?
Yeah, I'm glad that you asked me. So obviously I wrote a book that was published in 2022 called The Intermittent Fasting Transformation. So I spend a lot of time talking about this. I can always say this is the sign of someone who has evolved as a human being, because I still think fasting is a very valuable strategy. I find that most women fast too much, too long, too intensely. And so I think it's always in the context of, if you're sleeping well, you're not over-exercising, you're not over-restricting your diet. Could intermittent fasting be a part of your lifestyle? If you're still menstruating around your cycle, yes. If you're in menopause, yes, it can be. Do I think that I'm a fan of women that are not sleeping, that are, going through a divorce? They just got laid off. They're going through a big move. There's some extraneous stressor. They just had a terrible, tragic diagnosis of a loved one. There's extra stress going on in their lives. They're not sleeping well. They do chronic high-level cardio, and they never give themselves a rest day. And I see plenty of these women in programs. They don't feed themselves. There's a lot of women that hide their eating disorders in intermittent fasting. So those are definitely the people that I would say 12 hours of digestive rest, every adult can benefit from. And that's kind of the direction a lot of my messaging has gone in, is yes, I still believe in the value of intermittent fasting, especially for metabolically unhealthy individuals. But I think that there's an extreme pattern that I see. I always say it's the over-fasting, over-exercising, over-restriction of food people that I call it the triad. I'm like, these are the people that will crash and burn in perimenopause and menopause, because their body is just under an assault of too much hormetic stress. So we talk about cold therapy, heat therapy, exercise. Hormesis is a beneficial stress in the right amount at the right time. And for a lot of people, they go to extremes. And so it's helping people realize what is the right relationship with meal timing for you as an individual at this point in your life. It might be that 6 months from now you can go back to fasting a couple days a week, but I just find a lot of women use it as it's like this. I describe it as this ability to embrace a healthy habit and just take it to an extreme where it's no longer beneficial. It becomes detrimental. And so it's the nuance of fasting that I think is important. I think fasting in many instances, this novel fasting, there are a lot of exercise physiologists that are coming out against women having fasted workouts. My N of 1 experiment was last year when my dad got sick and died. I decided I was reintegrating myself and getting serious about weight training, because one of the things that contributed to my dad's death was sarcopenia, frailty, falls, fell and got two subdural hematomas. And I decided I was going to hire a trainer who nicely kicks my butt twice a week. And so it's with this understanding of, if I'm intermittent fasting, then I'm having trouble building muscle, for me personally. So I need to back off on the fasting. I'm still doing 12 hours of digestive rest, and I don't exercise fasted ever.
There you go.
And that has been interesting. And so when I had Stacey Sims on the podcast, she was like, I'm so proud of you, because, your platform is built on this concept, and I'm like, I still believe in it, but I'm just telling you, I transparently, my perspective is evolving as I'm trying to build muscle. And it'll probably take me an entire year to put on 5 pounds of muscle. And that's with HRT and the protein and the exercise. And so I think it can be the right strategy at a certain time in your life. It doesn't mean there's anything inherently wrong with it, but I find a lot of women don't do it right.
Yeah, I agree with you. I think that the women that do it, in my opinion, are the ones that are having the over cardio, the overtraining, the over food restriction, and then they're adding fasting to that, and those are the only women really doing it for the most part. And it's like you're not. If I were you, the first thing I would stop doing is the fasting, and then back off the cardio, right? And then let's see if we can get you into a hermetic level where you're actually thriving and gaining muscle instead. Where I do find it's helpful is for men and women that have some visceral fat that they need to lose, that are very sedentary all day long, that have metabolic health issues, a high fasting insulin level, that don't have a regular gym routine. And so you can almost tell who should be fasting and who probably should avoid fasting. But unfortunately, it's the opposite in who actually does it sometimes. And so my conversation around fasting is always like, let's look at everything else first, and then let's see if that could be a tool that we use as part of the overall program with appropriate monitoring as well. I did find fasting to be almost universally helpful in people who's have some level of metabolic health issue and they couldn't get their continuous glucose monitor curves to not be so erratic all day long. And when they started fasting, their curves smoothed out quite dramatically, actually. So it's a good tool if you're struggling with your continuous glucose monitor and getting a stable glucose curve, I think, too.
Yeah, I think that's a good observation. I mean, I found fasting and walking after meals,
Yes,
because you have those GLUT4 transporters that'll help kind of scavenge up the glucose. So those two things for my sedentary people that are like, don't ask me to go to the gym every day. Don't ask me to do that. I'm not going to weight train. I'm like, okay, let's just start fasting. Like, let's just start there. You have a compressed feeding window. Right. And that can be magical because that can then lead to someone saying, okay, now I'm ready to do more because I'm seeing results.
Exactly.
And they can be very results oriented. They're like, I've lost 20 pounds. I feel so much better. Now I'm willing to do the 5 other things you asked me to do. And so visceral fat is important to kind of distinguish from the kind of pesky fat that women in particular don't love. Visceral fat is what's around our major organs and is the pathogenic, tends to be very inflammatory fat that we want to avoid as much as possible. So when grandpa says to you that he has to drop, he's lost an inseam in his pants, because, he keeps putting his belt down lower and lower and lower.
Yes.
That's a sign that, there might be some visceral fat issues. But it's interesting, like observationally when I travel, I sometimes will see people and I'm like, I don't even think some people are even aware. Like no one's having the conversation to say, hey, visceral fat is toxic. Visceral fat is the stuff we want to avoid, like our life depends on it. And so, if you think someone having a beer belly is cute or someone that has a body habitus of like Santa, it's helping people understand or women that are very apple-shaped. And I see a lot of menopausal women that'll come in and be very apple-shaped and they'll say, oh, I've got a really skinny butt and legs and I've just got a lot of fat around my abdomen. I'm like, okay, that's important and we need to talk about why that's so important.
Right, exactly. I think I notice a lot when I travel too. I sometimes look around the room and 75% of the room, they have over fat visceral adiposity. And it's just so prevalent. And if there's one thing you want to focus on to work on first, I would say, is also your waist to hip ratio.
Yes.
Start measuring, start doing all the things. We'll do another episode on visceral fat reduction, but it's all the things, right? It's getting your glucose curve under control, looking at your hormones, reducing inflammation, and it all contributes to loss of visceral fat. But that's one of the first things we need to do as a population too, is lower the amount of visceral fat we have overall.
Well, and I think about other easy things when we're talking about this is cold exposure. You don't have to necessarily be in a cryotherapy chamber, but 30 seconds at the end of your shower, getting some cold exposure. I mean, that can be very, very helpful for stimulating this brown fat thermogenesis. And so for a lot of people, it's helping them understand that there's a lot we can do without any fancy testing, things that people can do from home. Because I'll have patients sometimes say, my budget doesn't allow for X, Y, and Z. I'm like, okay, then we're going to re-engineer something that will mimic that at home. And so sometimes those 30 to 60 seconds of cold showers can be helpful for stimulating that shivering response. We had a couple household repairs where we had our hot water turned off for these things that we were doing with this exterior build. And I had more than I care to admit, several days of cold showers. Yep. And so I kept saying to my husband, he was like, I'll just wait till the hot water comes on. I was like, oh no, I've got stuff I need to do. So I was like, this is a lot of hormesis, but it's this is perfect. It's I don't need to do cryotherapy today.
Right, exactly. No, the cold shower works really well.
It's very effective.
One day someone will do a study, but obviously, it would have to be Kohler or some shower manufacturer saying this is just as good as a cold plunge.
Exactly.
Right? I wanted to touch up base on one last thing with you. I know we've been talking for a while, but you and I had a very interesting conversation about the concept of dysautonomia. And, you're a big follower of your HRV. And I would love for you to just talk to the audience about what is dysautonomia, why is HRV such an important biomarker. I also think HRV is a biomarker that needs to be brought to the front of our conversation now. The more and more I learn about it, it's just so important. So take it from there.
Yeah, no. So dysautonomia is this imbalance in our autonomic nervous system. And this can happen for a variety of reasons. I suspect, I have multiple autoimmune conditions that are in remission, but that is probably one of the primary drivers. And I was sharing with you that I've always craved salt, but I never really understood why. So I'm someone that is very proactive about electrolytes. So you can imagine 16 years in cardiology. I mean, I am an electrolyte goddess. Like I know how to replete electrolytes in anyone.
Absolutely.
And so I was always very proactive about salting my food and electrolytes. And so I know there are things that will trigger a reduction in my heart rate variability, which is this balance between the autonomic nervous system, parasympathetic and sympathetic nervous system. Sympathetic is, fight, flight, or flee or fawn. And then parasympathetic is rest and repose. That's the easiest way to explain it. And so most of us are sympathetic dominant. We don't have enough parasympathetic stimulation. I know where my heart rate variability is when my autonomic nervous system is better regulated. And so for me, we were walking through Next Health and I was saying, when I did HBOT, so hyperbaric, my HRV just flew up. I mean, it was like 20 to 30 points higher than where it normally is. I know there are also things that will impact my HRV quite significantly beyond just being sick, which thankfully doesn't happen very often, but travel, especially jet lag, will tank my HRV. Or the other thing that I found is really impactful is being at elevation. So when I'm in Denver, my heart rate variability is in the 20s and maybe even the 15s. Like I laugh about it, at least now I know. But heart rate variability is another way to objectively measure how stressed your body perceives that you are. And so for me, it is something that I'm always kind of checking in with because it is my objective, tell-all. I'm the only person that looks at it, but it's my way of saying I need to do a better job of taking care of me. So I just finished writing a book, and I can tell you my HRV was low for about 6 to 8 weeks as we were trying to get it finished and brought in on time. But I think HRV is something that you can monitor through technology. So for a lot of people, your Oura Ring, which is what I have on, or a Whoop Band. I'm sure there's other technologies that are kind of budding that are out there. In fact, there was an influencer on social media that was trying out a bunch of different companies' rings to find out which one worked best. But this is what works well for me. But dysautonomia can show up in different ways. And for some people, it can be blood pressure related. They can have issues with hypotension, which is, I've always had a low blood pressure, but I didn't really understand why. There's specific ways that you can test for it. But for some people, they have extremes of dysautonomia. There are a lot of people that I'm reading in the literature and hearing from colleagues post-vaccination are seeing a lot of dysautonomia that's significant and profound. Some people are debilitated by dysautonomia. We saw quite a bit of it in cardiology. We would oftentimes do tilt table testing. But now there are dysautonomia centers that usually people will get referred to that are doing, kind of cutting edge vagal tone, things that are very beneficial. But what it has taught me personally is anything that's stimulating my vagus nerve, anything that's, the vagus nerve is the longest nerve in the body, but things that, humming, gargling, singing, things that bring me joy are all very important for getting me out of the sympathetic and, a lot of things that I do in my daily life that kind of help keep my autonomic nervous system. So the right types of exercise, getting on PMF mat, being married to someone that is very calming to my nervous system, not being in a house that's very stressful. I grew up in a house where there was a lot of yelling and screaming and physical violence. And so for me, being in an environment that's very different than that is very important. And then honoring boundaries. I would say to anyone that is, addressing or dealing with dysautonomia, boundaries and having boundaries and being very clear about, where your line in the proverbial line in the sand is. So when I travel, I don't overload my schedule. I'm very particular and conscientious about who I spend time with, who I talk to, the people that I choose to interact with, because I think that's also part of it. But dysautonomia is a spectrum. Mine is very mild. There are people with very debilitating dysautonomia. So I don't want to make it sound like my dysautonomia is representative of what everyone experiences. But for me personally, these are the things I've figured out work really well for me. And that salt and electrolytes are huge. They're enormous for me.
Yeah. I think it's an important topic for people to do more research into. Maybe we'll have you back one of these days when we do a deep dive into dysautonomia as well. But I found HRV to be a very helpful biomarker, and especially the better and better these rings get at tracking it. And once again, it's all about trend lines, right?
Yes.
I mean, you look at the trend, and if you're seeing month over month, things are not headed in the right direction, it's time to make some changes. And so I had a meditation back into my life. I took a break for a couple of years on meditation, but my meditative activity now has brought my HRV back into a zone that I'm used to. And then when I had the vaccine, it totally dropped my HRV, and I did a lot of different things to get it back up. It took me 2 years, but these are all, this is very, forefront in my mind because I struggled for a long time. It's been going up and down for a long time. And there are things that you can do. You mentioned humming, singing, breath work, meditation.
Holotropic breathing.
Holotropic breathing, yes.
I only interject this because my own provider was like on my case for like 6 months. I want you to look into this. I want you to do it. Here's some resources. And I did it for the first time in September. And I was so amazed on the effect on my HRV for days. I was like, this 15-minute exercise. I was like, how is this possible? So I went to him and I said, I actually did it. And he said, I'm glad because you've been so resistant. I said, well, I did. I'm human. But things like that can be so instrumental. So you can find what works best for you. I don't feel like I have to do it all the time, but I do find that breath work is, for me, very important. The things sometimes you avoid doing because you don't want to do it are the things you need to be doing. So I just remind myself, just like yoga, I get out of a habit of doing yoga. And then I realize I need to do yoga more. And then I start doing yoga and I'm like, I feel better. So I think for each one of us, we have things we secretly avoid doing that we actually need to be doing.
Exactly. All of us have those. Wow, what a great conversation. We touched on so much. I love it. You're like a wealth of information. So I can't wait for your next book to come out because I want to have you back to talk about that. Could you just give us a little preview on what you're going to be writing about?
So I'm getting back to my roots. So my first book obviously was about women and fasting, but this book is, the working title right now is The Menopause Gut, but it's because there is so much that goes on in the gut microbiome in perimenopause and menopause that impacts bone health, immune function. It's not just about sex hormones, but it is so significant and profound. And my story that kind of starts the book off, I'll just share that story now makes so much sense to me as to why I got so sick and led to that 13-day hospitalization. So it's going to be a book that will fit and dovetail nicely into the perimenopause books and menopause books that are out right now. And it's looking at things from a very different perspective. I mean, the changes that go on in the gut have a systemic effect, not just on mood, on sexual health. It impacts everything. And I go in and talk in depth about signaling molecules and do it in a way that's super accessible. And I talk a lot about hormone replacement therapy and the value of that. Because as an example, like estrogen and immunity are like peanut butter and jelly. Terrible analogy considering there's a lot of peanut butter allergies, but they go together like lock and key. And with that loss of estrogen, our gut microbiome is just much more susceptible to opportunistic infections, leaky gut, food sensitivities. There's just a lot that suddenly I was like, oh, this makes a lot of sense. Yeah. So I think it'll be a really important book that will fit in nicely with the rest of the perimenopause and menopause books that are already out and that are coming out in the near future.
Yeah, no, I think having more resources around perimenopause is definitely needed because no one's been writing about this for years. And now we do see some more authors like yourself and, Mindy Pelz, who's a friend of ours, and my friend Vonda, right? Do you know Vonda?
I love Vonda. We were just texting this morning.
Oh, that's awesome. Oh, we should send her a picture of us. But she's writing a book on
Broken.
Yep, exactly. And so that's going to be a great book also. So I think every woman should have a library of these 4 or 5 books so they understand what's going to happen over the next 5, 10, 15 years once you start the journey. And there are things you can do. It doesn't have to be as bad as it's been for our mothers and grandmothers, right?
Absolutely. And what's interesting is when I interviewed Vonda for the first time, I was telling her about the chapter I was writing, which at that time was on the gut-bone axis. And she was so excited. She was like, I'm so glad you're writing this. And she's like, I'm writing a whole book about a lot of these topics, but there is so much relevancy to the things that we're just not exposed to. And so it makes it accessible. Like it's written for the lay public, but I'm confident clinicians will find it to be an invaluable resource as well.
Yeah, no, and that's what I love about you in particular and Vonda and people that actually see patients writing books, because I think we talk to patients every single day and we figured out the best way to make this information accessible to the regular person and how you can incorporate it into your life with the nuances of everyone is different, right?
Yeah.
And so you have to give people different options. You have to help people find out where they are in the spectrum of the options that are available and what's going to work for their biology. And we have these conversations every single day, so we know how to do that. And so this book is going to be an incredibly valuable resource to women that are looking to navigate menopause. And specifically, like you said, it's a topic that most people don't talk about, gut health and how that relates to menopause.
Yeah, it really does impact everyone. And that's the one thing that, I when I was pitching my idea to my editor, I was saying, I have this really great idea because I'm interviewing all these experts. And I'm like, there's a hole in the literature. And I have been doing stool testing for 9 years, looking specifically. And I'm like, this now all makes so much sense. So thank you for that. I look forward to coming back.
Thank you for that. How can people find you?
Yep. So probably easiest to go to my website. So it's www.cynthiathurlow.com. Get access to my podcast called Everyday Wellness. You've been a wonderful guest on there. And I'm active. I always tell people I'm active on Instagram. My team is on TikTok. We do have a free Facebook group that's called the Midlife Pause / my name on Facebook. Totally free. There are men and women in there. There are men trying to better understand their significant others and spouses. And that is a free Facebook group. And you can post questions in there that my team and I actually answer questions in that group myself. But yeah, that's probably the easiest way to find me. We're slowly growing on YouTube, but that's where we put the full versions of the podcast out. So people, if they want to watch the video and the audio, they can see it there as well.
Yeah, we do the same thing. This was incredible. Thank you so much.
Yeah,
I
so
really
glad I made it
appreciate
happen.
you coming and can't wait for more conversations.
Absolutely. Thank you.